Bihar Swasth Suraksha Samiti, the society which the state has set up for implementation of PMJAY in Bihar, is also here. We have a very eminent panel with us, and I'm going to introduce all of them very briefly to you. We have Sisir Debnath, who is an assistant professor of economics and public policy at Indian School of Business. He is a PhD from University of Virginia and does research on health economics, development economics, empirical microeconomics. His research is supported by several grants from International Growth Center, MacArthur Foundation, JPAL, Post-Primary Initiative, and EY-ISB Initiative for Emerging Markets. He writes about his research in various media outlets. So, Professor Debnath, you're welcome. Then we have Anup Malani with us. He is the Lee and Brenna Freeman Professor at the University of Chicago Law School and Professor of Pritzker School of Medicine, a Research Associate at the National Bureau of Economic Research, Boston University, Scholar at Resources for the Future in Washington, a Senior Fellow at Sheffer Center at the University of Southern California, and an editor at the Journal of Law and Economics. He is the founding faculty director of Tara Center for Development at the University of Chicago, which undertakes and evaluates development interventions in India and trains Indian government and NGO officials. He is a PhD in economics from University of Chicago, and he has a wide repertoire of research under his belt. Then I also take this opportunity to welcome Tarun Jain, a PhD in economics from University of Virginia and an assistant professor of economics at public policy at the Indian School of Business. His research focuses on understanding causes and consequences of human capital formation, especially in the context of fast-growing developing countries. Gender is a topic of special research interest, given that women face persistent barriers in economic advancement. He has published papers and peer-reviewed journals such as Review of Economics and Statistics, Journal of Human Resources, Journal of Public Economics, Economic History, and European Economic Review. Then we have Chandrakant Lahariya with us. You're welcome here, Mr. Lahariya. He's a specialist working with the World Health Organization in India. He's a physician, public health specialist, and a policy strategist with more than 15 years of experience in the areas of health system strengthening, integrated services delivery, health financing, public policy, global health, and political economy of health. He has contributed to the drafting of India's first national vaccine policy in 2011 and is widely credited with establishing and strengthening institutional mechanism for decision-making on new vaccines introduction in the country. I welcome you. In fact, he's represented WHO in the various working groups and steering committee. Then we have Kiran Raj Pandey. Welcome, Mr. Pandey. He's a physician specializing in internal medicine and a health service researcher with the Center for Health and Social Sciences at University of Chicago. He's the founder and chief of research at Shastra Health Sciences, a health services translational research company that designs and deploys health services in South Asia. He did his undergraduate from Kathmandu University, followed by postgraduate residency training in internal medicine at Rosalind Franklin University of Medicine and Sciences in Chicago. And then he moved to University of Chicago, where he has pursued his fellowship training and advanced training in hospital medicine, as well as another fellowship in health services research. He has designed and evaluated service delivery models for non-communicable disease, tuberculosis, HIV/AIDS. And then we have D. Narayana. He is a PhD from Indian Statistical Institute, Kolkata, and is currently the director of Gulati Institute of Finance and Taxation. He was holding the position of RBI chair at Center for Development Studies before taking over as director of GIFT in 2012. GIFT is Gulati Institute of Finance and Taxation. He was at the State Planning Board and a technical advisor between 2013 and 16. He's written several books, Safeguarding the Health Sector in Times of Macroeconomic Instability, Policy Lessons for Low and Middle Income Countries. He has co-edited with Slim Haddad and Ennis Baris, and is published by Africa World Press, Trenton, New Jersey. Member of Kerala Public Expenditure Review Committee and chairman of Karunya Arogya Suraksha Padati, Kerala, in alignment with Ayushman Bharat Prime Minister's Jan Arogya Yojana. So you can see that I am the least educated here, and it's very difficult to chair a panel with such eminent panelists. Health is a major issue, and we always look at it in terms of primary, secondary, and tertiary care. Primary and secondary takes a larger focus of people who are part of the government. The tertiary care services are picking up. If you look at the data now, I think more than 50% of deaths are now taking place because of non-communicable disease. So that transition has been made where communicable disease deaths are lesser than what the NCDs are contributing. And for anyone who is part of the Bihar's health system, the challenge always remains, how do you devise and how do you fashion a healthcare delivery services in the state of Bihar, where 88% of the people are in rural areas with only 2% of doctors. 75% of doctors in Bihar are in the urban areas, 23 in what we call the small towns, the block headquarters, and just about 2% in the rural areas. It's a great challenge. Managing your HR is very, very crucial for us, and of course, infrastructure comes second. And HR issues actually make sure that your tertiary care services, especially the medical colleges, don't get manned adequately. We are operating at almost about 50 to 60% of our strength. We are in the process of setting up 11 new medical colleges in the state, but I think the HR challenge will remain for some time for us. If you see in terms of spending, Bihar spends almost about 1% of its SDP on health. And Bihar's per capita income is about 1/3 of the national average. So we are one of the lowest spending state in the whole country. Just about 450 rupees we spend per capita on health. But if you look at the outcomes, somehow the life expectancy of a person who is born in Bihar is as much as an Indian. You know, it's almost the same life expectancy. So what does it say? I mean, if you're spending 1/3 on health than what the national average is, and yet having the same life expectancy, then I guess there's a reason to spend more. Ayushman Bharat is a new scheme, and we do hope that it is going to change the fundamental scenario in especially tertiary care services, with its component also being a health and wellness center, which is at the lower level, to be able to screen people who may be having NCDs, refer them to higher places where they can undergo treatment, cashless treatment, free of cost. As per the SEC data which has been used for Ayushman Bharat, Bihar has got 1 crore 8 lakhs. That is about 10.8 million families who are eligible under this scheme. Out of this 10.8 million families, 10 million are in the rural areas and about 1 million are in the urban areas. We were one of the states who were doing Rashtriya Swasthya Bima Yojana, which we ran until 2016-17. But if you look at the figures of RSBY across the country, I agree that it was only a 30,000 cover, but less than 2% of people who were actually enrolled and were part of RSBY had actually availed these services at the hospitals. Without taking much time at this stage, I would request Sisir Debnath to kindly share his views with us on the subject.
Principal Secretary, for the nice introduction and setting the stage for the discussion that we are going to have today. And a big thank you to ADRI and Center for Economic Policy and Public Finance to bring all of us under the single roof and give us this platform to discuss this exciting new program on tertiary care that India is going to embark on. And I wanted to start, so I have the role of the moderator. I just want to make that clear. And we have about 90 minutes, so we'll spend about 15 minutes at the end for question and answers. And before that, I'll go over to each of the panelists to highlight us, to give us their views on certain topics, because we have from different, even though we are all working on the health sector, we have very diverse background. So I would like to start with the quote, like why healthcare needs a little bit special attention. And this is not now. A famous economist, Kenneth Arrow, way back in 1960s figured out or predicted that healthcare is not like other markets. It is different. And the difference comes from various reasons he argued in his paper, which I'm not going to get in. But healthcare requires special treatment, and that's why a lot of public intervention that you get to see here. And since these public interventions are made in healthcare in every country, particularly in India, despite having many, many interventions, we often get to hear that well, the program was designed very well, but somehow the implementation didn't really go that well. This is a common criticism, not only across the healthcare programs that are being launched in India, it cut across the theme, across education, and so on and so forth. Now, as an academician, we also face the same challenges. So when we are trying to do a big study, first thing we do is to do a small pilot. We want to test whether this is going to work or not, and then learn from it. Now, Ayushman Bharat is a very big program, one of the largest health program that is going to be run. And fortunately, we have Tarun Jain with us, who did an extensive study on another healthcare program that was conceived and run very well in another state in India, the erstwhile Andhra Pradesh, which is now Andhra and Telangana. And he has studied that program called Arogyasri extensively. So I'd just like to ask him to share his thoughts about what can we learn from the data, massive data that that program has generated? What are the similarities? What are the dissimilarities between Arogyasri and the Ayushman Bharat program? Tarun, yeah, stage is for you. So since we have limited time, if we could keep it between 6-7 minutes.
So thank you very much to both Dr. Sanjay Kumar as well as Sisir Debnath for my introduction. Sorry, so in a health panel, it's always a safe assumption. But I want to talk a little bit about Arogyasri. So the reason why Arogyasri is interesting is because it's a very large program, health insurance program run by Andhra Pradesh for almost now more than 11 years. The designers of Ayushman Bharat have explicitly referenced Arogyasri and its successes while coming up with the more salient aspects of Ayushman Bharat. So, but given that Andhra Pradesh is not a small state, the combined Telangana and Andhra Pradesh population is 80 million. And so we can learn something from the operations of this program for a long time and see what we can draw lessons from that. And if Ayushman Bharat has to make mistakes, it should make original mistakes which are, not, and not repeat the mistakes of Arogyasri. So let me just get started with this and structure these thoughts that we have, right, in a three-way problem. So in any health insurance program which is operated by the government, there are essentially three actors. In Arogyasri, there were three actors. You can, in a implementation of Ayushman Bharat, also think of a fourth actor. So, but the three main actors are patients. You can imagine that if you fall sick, you become a patient. You need to have some treatment. You have hospitals. Particularly in the new emergent landscape, we never thought of private hospitals as important. The hospitals were operated by the government, so they were part of the government infrastructure. But in the health insurance schemes, the public Ayushman Bharat style, we'll have hospitals as independent players, and finally there's the government. So what are the concerns of these three operators? And these are very important to keep in mind, and particularly in our analysis of Arogyasri, these were key concerns. So first is that patients, right? We tend to think of poor patients as, they don't have options. But actually, in our study of Arogyasri, we found that the program, and this will be almost universal, is that patients can choose hospitals. They are going to choose hospitals they might be living in a rural area, and they're willing to travel to different places, particularly in large cities. They are aware of quality of care. Right? So they're going to think about what quality of care different hospitals provide, different private hospitals provide, right? And even in an environment where the government is paying by the procedure, at the same time, the patients are also incurring multiple costs when they're accessing care. So, for instance, a hospital located very far away is going to involve much more travel costs, stay cost, all these things. And so this cost of access is still borne by patients, even when the government is providing reimbursement to hospitals. The hospitals, by the way, also have to choose. Private hospitals can always choose to stay out of programs and not participate in in the government program. And this is something that is key. Private hospitals think hard about their profitability. Even when they're publicly spirited, they think hard about profitability when they're choosing whether to participate or not. Conditional on participation, they think about what quality of care to provide. So think about, say, a heart patient, are they going to invest much more into making sure that the heart patient recovers well, keep them around longer, so on and so forth. So they can increase the quality of care or decrease it. And a key component of that is that they incur higher costs when they provide higher quality of care. They also care about their competitors, right? So, in Andhra Pradesh particularly, there are a large number of private as well as government hospitals, and the quality of care is provided much more when there are more competitors in the same market, in the same district. So finally, there's the government. So the government has to make decisions as well. They're going to think about reimbursement rates. And this has been a key issue in Andhra Pradesh. What is the reimbursement rate per procedure to provide? This is not the maximum cover per household. Currently, we are talking about 5 lakh rupees as Ayushman Bharat's cover plus household. But in addition, there is also a decision to be made about what is the reimbursement rate to provide to the hospital. Say if there's a long bone fracture or an open heart surgery, how much to compensate the hospital. And this has been an important aspect of the government's decision as well. Of course, the government can provide high reimbursement rates. Then all the hospitals will want to participate in the program, because they're going to per procedure get a lot. But then the problem is that the government will run out of money today, and tomorrow there will be no money left for patients tomorrow. So those are the trade-offs inherent, that today's patients can be taken care of by providing high reimbursement rates, and then there'll be nothing left over for tomorrow's patients. So this is the structure with which we thought about Arogyasri. The fourth player is the insurance company. Now in Arogyasri, there was no independent insurance company, so we are ignoring that for the moment. But let me just describe Arogyasri scheme in more detail. It was a health insurance program started by the AP government in 2007. It covered BPL families, but Andhra Pradesh has a very high poverty line. So almost 80% of the population was covered by it. So in that sense, it's as close to a universal scheme as you might imagine. It has no premiums, cashless, deductible, and for the time it provided fairly high coverage per family. There were a large number of treatments, and private and public hospitals all were empaneled in the program. Now, the key thing over here is that Arogyasri was quite successful. A very large number of people actually participated in the program. And by 2015, more than 3.3 million procedures have been taken place under various different categories in the 8th year of the program. Okay, so let me just sum up some important findings that we have. One is that quality matters. So so the Arogyasri program was kind enough to share a lot of data with us, and through that we've been able to investigate the workings of the scheme over the last few years. One is, of course, that quality matters. So it's not as if patients don't understand medical quality. They do. And particularly, patients recognize which are the hospitals that are likely to provide better services versus those who are not. Right? So patients can recognize quality quite well. The second lesson was that distance matters. So patients like to have services close by rather than far away. The third is that informed patients particularly, those who are from within a local area, so in this case we defined it as a district, are willing to trade off quality and convenience, right? So distances. The fourth lesson was that there's a positive correlation between quality and hospital market share. So when hospitals provide better quality, they actually attract more patients, and this is a key lesson, right? So in a competitive environment, this was a particularly important finding, that when competition increases for hospitals, the best way for them, the private hospitals, to get more patients was to increase their quality of care. And the last lesson is that the cost of care that we have learned about is much higher for urban hospitals than for rural ones. And so this means is that the rural hospitals, it's profitable for them to participate in the Arogyasri program, but not so much for the urban ones. So if you have a single reimbursement rate per procedure and through the entire program, what will end up happening is that a lot of urban hospitals will not participate in the program, whereas for rural hospitals for whom the costs are inherently lower will participate in the program. So this is a key lesson for policymakers to keep in mind when they're designing the reimbursement rates for the different programs, right? I just want to end by addressing two important points that I've seen in the newspapers, in the press so far, as perhaps criticisms of the Ayushman Bharat, and what we can address with this Arogyasri lessons. So first is that I read a report by Professor Jean-Drez, who's a very eminent economist. We've all learned a lot from him. But he said that even if the annual financial outlay for Ayushman Bharat was 10,000 crore rupees, he called it chicken feed for the purpose of providing health insurance. He said that it comes out to be only 200 rupees per person. Now that number is accurate, but actually, we did some calculations for Arogyasri as well. And what we learned over there is that we took a look at the total expenditures over the entire time period of 2007 to 2015, a time in which 31 lakh procedures were performed. The key lesson over here is that per procedure, the cost is 24,000 rupees per procedure. So when we talk about 5 lakh rupees as a coverage, I have to tell you that most households will not use that. 5 lakh rupees corresponds to multiple organ failure and long stays in the hospital. And thank goodness, most of us don't have that every year in most households. Instead, what happens is that the coverage is actually used quite rarely, simply because most patients who are covered by the program will use the program only once or twice in their entire lifetime. In that case, a 24,000 rupee procedure is actually quite effective. So we also took a look at what happens if the PMJAY budgets 200 rupees per person. Because most people are not using tertiary care every day, essentially this works out to be about 20,000 rupees per procedure, which compares well with Arogyasri's success of a cost of about 24,000 rupees. So the 10,000 crore rupees per year to cover 50 crore households, 50 crore families, individuals, is not an unrealistic number in terms of public finances, right? So this is one lesson. The other lesson that I read about is, just choosing individuals. So, this is Anil Swarup, who was one of the designers of RSBY. And he talked about the, key problem, which is identifying who is a beneficiary. And for some reason, we have decided to slice and dice our population and saying that this person is, eligible and this person is not eligible to participate in a program. And, Ayushman Bharat will use the latest socioeconomic and caste census, which none of us have access to. Only, select individuals in government have access to this data. And so this secret data set is going to, sorry to call it this, but is going to be used to determine who is eligible and who is not. And so, in addition, this Ayushman Bharat will then use a fancy computer system, networks, so on and so forth, to check beneficiaries against their Aadhaar information, against the socio-economic census in a real-time basis. So, so Anil Swarup is flagging the fact that it's very difficult to identify when someone shows up at your door with a medical emergency to know if they're a true beneficiary or not. And, if the per procedure outlay is only 20,000 rupees, my argument is, why restrict the program to 50 crore individuals, we can perhaps increase budgetary outlays and make this a more universal program. And one of the advantages is that you don't need to do all this inclusion and exclusion all the time and check on that. So a universal scheme might have these advantages of reducing errors on identification. It might also create a larger market for the public sector, for the private sector to enter. So many more hospitals might be interested, many more hospitals might come up. We talked about the HR challenges. Many more doctors might be trained, nurses might be trained when we have greater financial outlays, right? And the final is one thing that one of my teachers taught me is that any scheme for the poor becomes a poor scheme. So the advantage of having a more empowered individuals also be beneficiaries in the scheme is that they are the people who make noise anytime something goes wrong. And so whenever you have a more inclusive scheme, perhaps it will just operate better because there's this implicit monitoring built in. So my time is up. Sisir is raising fingers, so I will then end up over here and cede the floor.
Thank you so much, Professor Jain, for sharing the insights of your research from using the Arogyasri scheme in Andhra and Telangana. I would request Professor Malani to talk a little bit about the vast body of research and experience that he has in the healthcare to draw upon that, particularly the experiment that he did in Karnataka on the enrollment of RSBY. So it is not that Arogyasri is the first time that India has rolled out an insurance program on tertiary care. Before that, we had Rashtriya Swasthya Bima Yojana, which was enrolled with much limited capacity to very selected few individuals. And Professor Malani does a fantastic body of research which looks into the causal effects of what are the effects of enrollment on healthcare. And unfortunately, there are also few anecdotal examples, few rights that we get to see that this program was not as successful, particularly the rates of utilization. So what is his thoughts on this issue? Professor Malani, up to you.
Great, thank you. Thank you also for the nice words, and I really enjoyed learning a lot from Tarun's work on Arogyasri. As Sisir said, we have been working, me and my research team have been working on understanding Rashtriya Swasthya Bima Yojana, which is the largest public health insurance scheme we have at the national level in India since 2013. So I want to tell you a little bit about that program, and then since we are moving over to Ayushman Bharat, I want to tell you a little bit about the differences between the two programs so you can see what we learn from, how applicable what we learn from RSBY is to Ayushman Bharat. Okay, so let me start by quickly telling you about RSBY. So RSBY is a program that was begun in 2008. Intended to cover BPL populations in certain groups based upon their occupation. So for example, railway porters and the like. So it covered, its goal was to cover about 280 million people, roughly speaking, and it covered about 170 million people in the end, although estimates vary. Its coverage, that was the eligibility, but the coverage of the program was to provide BPL families with 30,000 rupees worth of annual coverage for tertiary care expenses. And this would cover about 5 members of any given household. And so this was a 30,000 allocated across those 5 individuals. You could go get care, and this is secondary care, not tertiary care, so this is a contrast with Arogyasri. It covered secondary hospital care at any impaneled hospital. And those impaneled hospitals varied across states. There was a small premium. It's really functionally a free program, but you had to pay 30 rupees in order to get a smart card. That smart card made you eligible for getting health care at these impaneled hospitals. However, like Arogyasri, there's no deductible, there's no copay, which is an important distinction between the sorts of insurance programs we see, say, in India and the ones that people talk about in places like the United States. This is a program that was run because there was a smart card. It was a cashless scheme. That was a very important measure to make it function well. It was administered, at the state level, even though the program was set forth at the federal level and 75% of the funding came from the federal level, the central government, it was administered by states. So there's variation across states in how it was administered and how well it performed. An important feature of the program was what the government did is held auctions, basically tenders, at the district level and asked insurance companies to bid on who would provide the benefits that would be provided by the scheme at lowest cost. So there were these tenders. You would select an insurance company for each district, and that insurance company would, for the premium period, say a year, provide the coverage that I talked about. And that's important because even though it's federally funded, the federal government and the state governments paid for premiums, but it's private insurance companies that provided the insurance. And there's a reason for that. Private insurance companies have some experience in providing health insurance, even though it's not as extensive insurance as you would, or history as you would see, say, in a place like the United States. Okay, so that was the nature of the scheme. Back in 2003, so about 5 years after the scheme started, we worked with the state of Karnataka to run a large-scale randomized controlled trial involving about 55,000 individuals, 11,000 families, in 2 districts of the state. So we looked at Mysore, which was in the south of the state, and we looked in Gulbarga, which is in the north of the state. And we did an RCT where we assigned people to 4 different groups. And before I tell you what those 4 groups are, it's important for me to tell you a little bit about the eligibility. One of the reasons we did the study was to understand what the impact of RSBY is, but we also tried to be forward-looking. We knew, or we expected, that someday India would expand eligibility for under its public health insurance scheme to more than just BPL populations. We knew that some APL populations would be included, so one of the other goals of the program, of the study, was to understand what is the impact of RSBY if we expanded eligibility to include APL populations. And so that was the group of people that were enrolled into the study. And so what we did is we randomized people to have, households in particular, to have access to insurance in 3 different ways, and then a control group. One group we gave access to RSBY for free. It's kind of like a public health insurance for free program. A second group we gave access to we gave them the right to buy RSBY. We call this a public option in the United States, but basically you get to pay the same premium the government does, and then you get access to RSBY. It's a little bit lower cost approach to providing access to health insurance. Looks a little bit like Medicare Part A in the United States. A third group, we gave them the ability to buy, or the right to buy, health insurance, RSBY, but we also gave them a cash transfer, an unconditional cash transfer equal to the premium. Just to figure out what the impact would be if there was a budget neutral access to RSBY. And then the last group was a control group. So we did this back in 2013, and we've done several rounds of surveys. So we have results after 12 months, after 18 months, and in fact we're in the middle of doing a survey now that will give us the impact of RSBY after about 4 years. One of the reasons we did this is we knew that sometimes short-term effects and long-term effects can differ for health insurance. One of the concerns people have is that, or expectations people have, is that health insurance over time builds up health stock, the stock of health that you have, and the performance of insurance might improve over time. So we did this study, and we looked at a number of different outcomes. We looked at uptake, we looked at, that is to say, uptake into insurance, we looked at utilization, we looked at the impact on a household's health, we looked at an impact on households' finances. And we found effects that are roughly in line with what the literature in the past has found. The literature that I'm referring to here is studies of randomized controlled trials of health insurance programs in other lower and middle income countries. So in terms of uptake, one of the things we found was that we had actually remarkable uptake. When we offered when we offered RSBY for purchase, that is to say we made people pay the premium, there was still a 60% uptake into insurance, which is similar to what we saw for BPL populations under RSBY, where it was functionally for free, which is not surprising. APL populations are going to have higher willingness to pay. It's not surprising that they might uptake even when they have to pay at the same rate that below poverty line populations would uptake at 0 price. So that was utilization. If you offered APL populations RSBY for free, they actually took it up at an 80% rate. Now it seems a little bit weird that not 100% of the population would take something for free, but if you even study, for example, the history of Medicaid in the United States, uptake of even free programs is difficult to achieve, and so an 80% uptake is quite remarkable, actually. It's just a program that requires people to show up to enrollment stations and get high uptake. When we looked at utilization, we actually found that utilization was not very high. Consistent with what you're finding in BPL populations for RSPY, as was mentioned earlier. Utilization rate among BPL populations in RSPY was something like 1 to 2%. It varied across districts in Karnataka. We found a utilization rate that was a little bit higher, that was around 4%. However, there was no increase in utilization in most of the groups. The only group that showed a significant improvement in utilization was actually the group that was asked to pay for RSPY. Which is consistent with the literature that suggests that when people are asked to pay for a product, they're more likely to value it and more likely to use it. Although the specific reasons for that we can go into if you'd like. So utilization impacts were not very substantial. Again, I want to stress this is not a unique finding. If you look at studies that were done, for example, in Mexico of Seguro Popular, you look at Cambodia, you look at Nicaragua, you look at Kenya, you also find no changes in utilization. And it's important to understand why that might be. One reason to remember is that it's not as if individuals don't have access to secondary care in the absence of RSPY. They do have access to public hospitals, and although RSPY expanded coverage to include private hospitals, public hospitals may be an adequate safety net. That might explain why there's not an increase in utilization. It is also the case that even without insurance, when people are paying out of pocket, that does not mean they don't have a method to finance healthcare. We do know that there are informal insurance markets in villages, and there is informal credit markets, so money lenders, so that people can get access to healthcare. So there was a dramatic increase in utilization for much of the group, and there might be good reasons for why that's the case. Now I want to turn to health. If there's not going to be a big utilization effect, you wouldn't expect a big health effect, and that's actually what we find, that at the 12-month and 18-month mark, we don't see dramatic differences in health outcomes. There's some statistically insignificant suggestions that people's self-reported health improves, but for specific things like diabetes and heart attacks and the like, we can run through a list. We don't see significant improvements in health. Again, maybe things will differ after 4 years, and so we should keep an open mind, but it's not there. This is consistent with the utilization effect. If there isn't a big change in utilization, you're not going to see a big impact on health. Usually health is associated with utilization, though not 100% all the time. The one thing that we did find that's quite interesting, though, is that in our finance, when we looked at our finance modules, we did a full asset survey of these households. One of the things that we discovered was that people changed their asset allocations. It appears they changed their asset allocations in response to having health insurance. Knowing that you didn't have to have money on hand in order to pay for emergency health care at a hospital meant that you could invest your money separately in a different way. So what would happen when you didn't have health insurance is that you would invest in assets that were liquid, that you could quickly sell, so that you could pay for hospitalization. But once you had health insurance, it appeared that what households did is shift from liquid assets to illiquid assets that were harder to sell. That's an important change because, as it turns out, illiquid assets offer a higher return. And so what we observed in the data is that there was a shift from illiquid to liquid assets, income rose, and there was a commensurate increase in consumption as measured by annual expenditure budgets among households that had insurance versus those that didn't. So while we might be a little bit disappointed in the utilization results and the health results, we should be a little bit optimistic about the financial results. And in fact, in the US, all the recent studies have suggested there's consistent understanding of insurance in the United States. The primary impact of insurance in the United States, such as from as measured by the Oregon Health Insurance Experiment, for example, is that not that it improves health, but because insurance is a financial product, improves your financial condition. It provides reduction in risk. And that's exactly what's going on here. So I know that the time is limited, so I want to just quickly wrap up. So we do find that RSPYs has not a significant utilization or health impact, but it has a financial impact. I think that'll change the way that we think about Ayushman Bharat and the expectations we should have for Ayushman Bharat. But there's a lot that we can learn about some of the failures in RSPY. Maybe during discussion we can talk about that.
Thank you so much for sharing the early results, Professor Malani, and of course the interesting results that he finds that the precautionary savings that households keep in a liquid form in their banks, suddenly they start investing. And it gives us immense hope that if the coverage is 5 lakh rupees instead of 30,000 that was under RSBY, the economic case for providing universal health care becomes even stronger. It's not only just improving the human capital, it is changing the financial portfolio of the households. They're putting money in more illiquid assets, potentially for future higher returns. So maybe more income to be generated in the future as a result of Ayushman Bharat. But we started talking about insurance a lot, but at the same time, this is often not that highlighted, that apart from insurance, this entire program, PMJAY, has another component to it, and that is to revamp, or at least try to make some corrective changes in the primary healthcare service provision. And I would like to have Dr. Lahiri discuss a little bit on what, because he had been associated with designing these fitness and wellness centers that the government plans to roll out. He has done quite a bit of work. So if you could quickly share your insights on this. Thank you.
Thank you very much for inviting me to ADRI, and thanks to the chair and moderator. I'm a medical doctor, but I work with many economists, and whenever such question is posed to them, what the answer is. It depends. But I would try to do a little better than that. So moving in this direction, whenever any program is started, there is an objective of doing it. And India, before launching Ayushman Bharat program, launched National Health Policy, which has a goal of universal health coverage. So let's understand in the context of what UHC is. It's about that people should be covered, all people, individual communities. They should have access to services. Those services should be good quality and something which is affordable to them. So that's the purpose of UHC, or universal health coverage, or WHO definition. If we simplify why UHC is required, UHC is needed for two purposes. And it can be said that one is a financial protection, which means people should not be falling into poverty when accessing health services. It also means that health services should be affordable to them. So that's one goal of aiming in that direction. But second, or equally important goal is that people should be healthy. The health outcome should be good. So that's what we want to achieve through UHC, which India has committed through National Health Policy. And in that context, if we look at the Ayushman Bharat program, there are two broad objectives or goals from UHC, and Ayushman Bharat program has two components. One is a Pradhan Mantri Jan Arogya Yojana, and second, Health and Wellness Center. Now, if we compare that, the financial protection, which is a goal of UHC, can be measured in two forms, like many forms, but two broadly used: catastrophic health expenditure or out-of-pocket expenditure. In India, this is one of the highest in the world. Around 62% of total health expenditure is out-of-pocket. Out of that, nearly 1/3 is on hospitalization and 2/3 is on outpatient services. So launching a scheme which is aiming to provide access to hospitalization service will address 1/3 of total out-of-pocket expenditure. If it's universal, and if it's for 40%, it will address some of those. And Health and Wellness Center, and moderator highlighted, is equally important component of this, which aim to strengthen primary health care. And primary health care can address both components, because out-of-pocket expenditure are higher as a total on outpatient services. So health awareness, if you have a stronger primary health care, it will reduce that well. So it will both improve outcomes in terms of both goal of UHC. It will provide stronger primary health care, will provide both financial protection, because as you see up there, that 2/3 is on OOPs, on outpatient services. So of the two components of Ayushman Bharat program, the point I want to make here is that first one, PMJAY will reduce OOP on hospitalization services and of course improve health outcome, but these are a smaller one. Health and Wellness Center and moderator well defined are equally big and probably more important. Rather, I would go to the extent that Health and Wellness Center initiative could be the foundation on which entire Ayushman Bharat program can be built. Having said that, it's a good beginning. It's a good beginning in the sense of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, that first time India has experience at the large scale, though there was state scheme, that provider and payer are being separated, which is a good approach to a stronger health system. It's an opportunity which provides people a choice to go to a provider. They can select whether they want to go to public provider or private provider, and without worrying that they have to pay, because this is being covered. And it is also an advanced approach that country is moving from paying for inputs to paying for outputs. So it's definitely a big step. But we all should also be aware that a scheme which is of 10,000 crore, however, in India, the total health expenditure is of 5 lakh crore. And out of that, 60%, 62% comes approximately 3 lakh crore. So total what people spend from their pocket on health services around 3 lakh crore. And a scheme of 10,000 crore will make only some difference. So we need to keep expectations real. It will reduce catastrophic expenditure, which is when families spend a particular fixed amount of money on health expenditure in monthly, usually around 10%, but it might not reduce or it might not have a big impact on OOP, and we should be aware about that. And especially it's restricted to for lowest 40%, even less. Health and wellness center is even bigger component. I already highlighted about it. The key is it would strengthen further the primary health care. And out-of-pocket expenditure, or rather the primary health care can tackle, and there is a global evidence, up to 80 to 90% of total health needs of the population. And it is responsible for 2/3 of OOP. Emphasizing from the health system perspective, both components are important, and even if we want to keep a balance. In my opinion, health and wellness center is bigger. Let's talk about another issue, that we should not confuse coverage with protection or financial protection or any health insurance. For example, in this table, what you see, that coverage part in any country should be closer to 100%, and catastrophic spending should be closer to 0%. Thailand has a nearly 95 to 99% coverage, and catastrophic spending on health is very low. But China has very high coverage, which has achieved over a period of time. But the catastrophic spending still continue to be high. And India, with a low coverage, still has a similar catastrophic spending. Intuitively, you look at this slide, there is something wrong, and that's the point here, that when we are moving in the direction of improving coverage, we should not be focused only on coverage. The focus should be on achieving what you want to achieve. And in the interest of time, I'll keep moving. Health outcomes are important. I already discussed about this one. Now come to the second part of discussion, and that is, will it make difference in the state? I would say that in a federal system, any national level scheme or union government run scheme is merely an opportunity to look within the state and strengthen the system. The ultimately state had to take initiative in that direction. And the 2 points or 2 arguments, I would say that it would depend upon what is achieved by any state, including Bihar, on 2 things. This is more or less similar to the presentation this morning done by Stuti Khemani, that state capacity and state interest will decide. The principal agent concept will decide. So 2 things which state of Bihar or any state should do, and that will decide the impact. That first, though broader framework of Ayushman Bharat program is there, but state need to decide that what it wants to achieve out of that. Whether want to increase access availability or move from disease focus to service focus, whether want to financial protection or all of them, or outside something. But within broader framework, what is need to be achieved? Or can Ayushman Bharat program at a state level be taken to the point that it become a development dialogue, or health agenda become a political dialogue? And these are the opportunity, and these will be harnessed dependent upon what a state does through ownership and initiatives. And second point I want to highlight is that it also had to come through innovations. And these are not exactly innovation, but in summary, I want to make a point that though Ayushman Bharat program talks about 40% population poorest, but there is always possibility that some states can go beyond 40% and some other approaches. There is example of Punjab and others, Uttarakhand and many other states which are going in this direction. Similarly, the innovation in service delivery are equally important. Primary healthcare approach, which is adopted across the country, is more or less similar for all states, but different states have made a different progress. It is what they did at the local level. For example, Kerala has a long experience in community participation, which is moving to the community engagement, and now empowering local institutions. Tamil Nadu or all other states, like you take example of Delhi, Mohalla clinics, or any other example, what additionally innovation they did, it will decide the outcome. Another 1 minute, I'll finish. So in Bihar, I wanted to come up with some concrete examples also that how this can be utilized. And this is the point here is that health decisions are not technical or bureaucratic decisions. Bureaucrats and technocrats have a sufficient knowledge and understanding, but we should also be aware that they work in a political environment and setting. So political, in economy perspective, you decide that what you want to do. Possibly one of the important steps for the state would be, if you want to expand national PMJY, then you need to build the capacity of official in strategic purchasing, think of extending primary health care. The key point here is, rather should continue to think about extending primary health care. Before moving on the direction of universal coverage scheme in Thailand, that was 2001 or 2, 1971 onwards, Thailand was working on extending primary health care. Ensure that additional people reach to those population. We heard the issue of challenges in the manpower, but what about upskilling the capacity of those who exist on the board? And new initiative should cater to the future. This is my second last slide. The point is that Bihar has done this in the past also. And I want to give an example of universal immunization program, which I worked for a few years. 1985 to 2005, Bihar had one of the lowest immunization coverage across, within the states, large states across the country. But in 2005, it had an initiative called Muskan Abhiyan, and it changed the story forever. It was an initiative, innovation, and many serial innovations. And now it's not the poorest performing. It shows that states have to take a lead. Programs run on the same model. In my opinion, taking that simile, Ayushman Bharat program is just another universal health immunization program. The difference is here, UIP is 100% centrally sponsored. This is 60-40 share and different purpose vehicle. To conclude and summarize, it's an opportunity for the states. Coverage is important, but not enough. Access to quality healthcare should be prioritized. HWC is a good opportunity. States need to take lead. Thank you very much.
Interesting presentation. In particular, the slide that I liked was that the comparison between India and China, that despite having completely different coverage rates, the out-of-pocket expenditures were very, very similar across these two countries. And over reading various materials, what is my understanding is that China didn't really invest that much in primary health care in the early days of its improvement in the entire healthcare system. So the primary healthcare system works as a gatekeeper so that diseases, they do not go out of control and then become a huge burden for the tertiary sector to handle. So even though the government is saying that we are going to announce this program with tertiary healthcare being taken care of, that doesn't mean that we forget the role, that gatekeeper role that primary healthcare sector plays. But from a different perspective, we can also think of the entire Arogyasri program as if a huge boost in the demand side of the entire healthcare market. The reason I'm saying that is probably one of the biggest predictor of demand, you all know, are prices. So essentially what it is doing, it's making prices zero for quite a big chunk of population and for selected procedures. So this is going to create a huge demand for services, particularly those which are listed or covered under Arogyasri, and the assumption is that the supply side is ready for that, right? So we cannot really expect things to work if there are not enough hospitals. But I would ask Professor Narayana to highlight this issue, particularly for Bihar. We are trying to boost the demand side of the healthcare, but is the supply side of the healthcare ready to take on that challenge?
Some of the results that I show here are part of a book in the making. The manuscript is almost ready, and I should thank ADRI for giving me this opportunity to share some of the results. Now, let me take off from where Chandrakant left off. Namely, health outcomes are dependent on access to quality care. Now let us this is just a table I went to the, Ayushman Bharat site, took the results for the state of Bihar, some of the districts. In fact, you have 23 specialties. I just taken 2 specialties just for illustration purpose. It could be any other specialty. What do you find here? You find district after district. It's basically the public institutions which are empaneled. There are hardly any private institutions, except in Patna and Muzaffarpur. So, if you are talking about choice, where is the choice? Of course, in the months to come and maybe in the years to come, probably choice will come about. But as of now, from the data that is put on the site, this is what you get. And what are these public institutions? Largely PHCs, and some districts, you also have referral hospitals and CHCs. Now, what is the problem? If you have predominance of PHCs for somewhat relatively simpler sort of a procedures. Now, this is also well known. I have presented the IMR and neonatal mortality as a proportion of the IMR for Bihar for the, from 2007 to 2016. IMR, of course, came down from 58 to 38. But you just look at the neonatal mortality rate. What has happened to that? See, it was about 50, 53, 55 sort of a thing in 2007. It has shot up to over 70 now. You see, ideally, if you have lot more institutional delivery, neonatal mortality should not be going up like this. So obviously, there is some problem with the sort of institutions where they are going for delivery. Of course, this is only part of the thing. If you look at the MMR results, you will probably get more or less a similar sort of result. In fact, there is a slightly different dimension to this. Now, when I say IMR, you can have IMR for female infants or male infants. I'm sorry to say, if you look at the results, there is something very, very disturbing. I will read out the raw numbers for Bihar. Male IMR, it declined from 44 to 31 between 2011 to 16. But female, can you guess the number? 2011, it is 45. More or less the same as the male mortality thing. But it stays put at that level. That's why the female, if you take the IMR for female divided by the IMR for male, what you find is that it has steadily gone up. In fact, it should not be behaving like that. As you know, mortality for infants, it should be higher for males. But here what you have is the reverse and a worsening situation. This is an issue on which I had worked a few years ago. There's a paper, and I'm coming back to that number, and it's shocking, because I thought things should improve, but it's not just Bihar. Elsewhere also you have similar sort of a, but let me leave that and come back to the public institutions. What's the problem? Look at the PHCs. This is it's a transition matrix that I have worked out. That's basically population covered per PHC. What is it that you find? You find almost all the states are lying in that diagonal sort of a thing. 10 years of NRHM, practically no improvement, except Jharkhand and Karnataka. Otherwise, most of the states are where they are over a 10-year period. And you know where Bihar is. In fact, if you look at the sub-centers, that is a transition matrix, I have not shown here, what you would find is in Bihar, as of now, you have one sub-center for 10,000 population, whereas the norm is about 5,000. In fact, the CHC also, it is no better. But of course, slightly better, because if you have a larger number of states which have moved leftward from the diagonal, that means the situation is improving. But where are they improving? You know, they are improving in states like Kerala and Tamil Nadu, where the situation is already much better. But you look at the states, you know, where improvement is needed, you don't see that. And Bihar also comes in there. And why is it that one is emphasizing this? In fact, the reason for emphasizing this is that normally one would associate with institutional delivery and whole lot of other sort of primary care that, you know, antenatal care, postnatal care, you know, this would also improve. But you don't see that sort of a thing happening. In fact, these are the sort of a numbers. This is from NFHS 4 for 2005-6, 2015-16. I don't think things would have improved in the last 2-3 years, but you know, this is the sort of a picture that you get. So institutional delivery has gone up, but IMRs have gone up, you know, not gone up, but has not come down in commensurate terms. MMRs, I have not given the numbers, but situation is not much better. So what it then points to is that expanding healthcare coverage does not necessarily result in better health outcomes. Now, in fact, already I think Jeff referred to that yesterday, JSY and you know, what's happened and all that. In fact, there is a recent article in the Lancet, which I just partly quoted that. Many of the births in the program occurred in primary care centers that did not have sufficiently skilled staff to address maternal and newborn complications, and hence did not result in improved maternal or newborn survival. So I just have to sum up. So what is Ayushman Bharat offering the people? In fact, going by the first slide, no choice, because there are no private providers. In fact, let me tell you from the experience of Kerala, the package rates, in fact, NHPS has come up with the 1, 3, 5, 4 medical packages, and they have given the rates, and the states don't have much flexibility to change those rates. There are some sort of we had a difficult time working that out in Kerala. So with such rates, in fact, we had a meeting with the private providers in Kerala. They said they are not going to participate in it. And then they made a huge press conference, and they said, with these rates, we cannot be part of it because we will not be able to survive. So it's not that the situation in Bihar would be any different, because most of these private people, I don't think will come for these sort of rates. And there is no guarantee that the rates are going to be periodically increased or anything of that sort. That's also an experience of the RSBY, because there is no mechanism for regular rising of the rates or anything of that sort. So one doesn't see, many of these private providers coming. And then if you have poor quality, then the sort of health outcomes that is expected from this sort of a program, you are not going to get that. So my final point, no alternative to improving the quality of public health system. That's why a lot more money needs to be spent on health and wellness centers. That's Chandrakant's point. Thank you very much.
Thank you, Narayana, for highlighting the point that even though there is coverage, even though it is paid for, but if there are no choices that there are very slim chances that people are going to utilize this effectively. What Tarun mentioned earlier in his presentation, that in Andhra people are exercising their choices just because there are hospitals, existing hospitals, and that particular supply side infrastructure particularly might be challenging for states like Bihar, Jharkhand, and UP, where the supply side of the healthcare is not that developed as in some of the southern states where their health insurance program has been running smoothly. Coming from a completely different perspective, I would request Dr. Pandey to talk about his experience, his international experience, on what are the challenges that organization, the supply side, faces while dealing with patients who come with government-provided coverages, and how did other countries, for example, Cuba, Costa Rica, and you don't have to go that far, Sri Lanka and Bangladesh has achieved tremendously in health sector, health outcomes in general in the past decade or so. So if you could share your experience from other countries, how they have tackled the problem of providing healthcare, quality healthcare services in other countries, especially in Southern Asian countries.
Thank you. I'm going to wear two different hats. I will start with my health services researcher hat, probably do a little rejoinder as a physician who has practiced here in South Asia, but also in North America. Oh, sure. Since this is a public finance conference, we've had a lot of talk around finances and financing over the last 2 days. But I think the issue around healthcare delivery in Bihar, as elsewhere, is a two-part problem. And it's first a part around financing. The second, and I would consider the more important and the more challenging part, is around delivery. And we've not talked at all about delivering healthcare, the nitty-gritties, the operational details of delivering quality healthcare to people. That's part because I think the conversation's primarily being driven by people from the Ministry of Finance, economists, and people like that. I think we, in the provider side of things, health services researchers, physicians have let the ball drop. We have not offered solutions. So I think I will try and tilt the table a little and then focus the conversation on that part of the equation. But even before going into the topic, I think it's important to understand what the real problem at hand is. I think someone said the most corrupting of lies we tell ourselves is that of a problem poorly stated. I will try to see if I can state this problem right. And here in Bihar as well elsewhere, I think this is a four-part problem. First is around that healthcare financing in Bihar, health spending is half of that as anywhere else in India. And even at a national level, even compared to low middle income countries elsewhere, India's healthcare spending is already abysmally low at around $260 per capita per person. Financial jeopardy for around 10 million people within the state of Bihar. Health facilities that don't function, or even when they do, they don't provide the kind of care that improves health outcomes. And I mean, even when there's health intervention that people have access to, that does not really improve health outcomes. And what's going to happen with Ayushman Bharat in each of these four domains? And I think we have an answer to all these questions with the foregoing presentations, especially the four presentations that we just had. Funding, I mean, abysmally low, probably Ayushman Bharat will improve the funding situation. It's less than 1% of the state GDP. Maybe this will go up. Let's be hopeful there. Financial protection, there's been conflicting evidence presented even within this conference. It could be a hit or miss. I mean, there could be some financial protection. There could be some income effects, as Anup just pointed out, but some other studies have shown that there might not be any financial protection. Health facilities that function, healthcare utilization that improves. Anup just said maybe not. Health effects, will there be promising health effects? Likely not. Why is it so? We're willing to spend billions of dollars here. We're committing already 10,000 crore rupees, and we sit here and decide and tell ourselves that there's probably not going to be health effects, but let's go ahead and do this anyway. Why are we doing this? But I think the problem at hand is we're not stating the problem right, as I just said before. And the problem is, it's not just a financing problem, it's a delivering problem. It's providing the right kind of health care, a care that makes a difference. And do we have examples of that? And the reason we get into a situation like that is because we are confused about what the problem is. And the confusion comes from this. And the confusion is that we're conflating between healthcare and health. We tend to think that providing healthcare in itself is going to deliver health effects, which has not been shown anywhere. I mean, you can provide, in fact, a little bit of insurance covers, and then you can do all these hysterectomies and then kill women and have terrible outcomes. And in fact, instead of helping people, you're actually hurting people, all the while wasting taxpayer money. So, and the second confusion that we have is, where does healthcare production really happen? I mean, there's been a great deal of theoretical work around this. Michael Grossman, back in the 1970s, put out a wonderful model, his health capital model, where he said that healthcare production happens not just in health facilities, but a lot of the healthcare production happens within families, within individuals taking care of themselves, within family members taking care of themselves, with communities coming together to take care of themselves, with communities acting in tandem in order to act upon the social determinants of disease, nutrition, sanitation, and primary healthcare centers that really provide the nitty-gritty of care, 80 to 90% of the actual pathology that afflicts our societies. We need to address those. None of the insurance schemes that are being discussed after 1993, all around the world, not just here in India, but anywhere else in the world, discuss any of these things. The only thing that we talk about is providing a certain amount of coverage, covering services at tertiary facilities, and then we go on and find 5 years later, there was probably not even utilization effects, certainly not health effects. Why are we surprised about this? There's no reason to be surprised. The reason we should be surprised is that we're not talking about what really we need to do in order to build health systems that really provide healthcare for people. And I just don't want to sit here, point at problems. I want to be part of the solution. I mean, I think, as I said before, we are the people who let the ball drop. And the way to answer that question is to look at health systems, country health systems, and community health systems that have really delivered the goods for their people. And I want to point at 4 examples from around the world. I want to start here in India itself. I find it a little surprising that nobody talks at this example. There is a little wonderful experiment. It's not even an experiment. It's a real thing going on in Jamkhed in Maharashtra. I'm not sure how many of you are aware. 2 wonderful doctors started this back in the 1970s and provided this comprehensive healthcare set of healthcare packages attacking the social determinants of diseases, providing income support, and providing the basic comprehensive health coverage that people need in order to improve their health. And they've gone on to improve their health outcomes as well as anyone else out there. Their infant mortality rate today is 17. Their health expenditures are very minimal. We do not want to, we do not care to scale that sort of model because that's a very hard, difficult thing to do. Elsewhere in Sri Lanka, they've done a very similar thing, very strong community-centered, public-owned primary healthcare facilities, and they've been able to achieve health outcomes that are at the top of middle-income countries, all the while spending only $350 per capita. That is as good a health outcome as anywhere else out there in the world. Everybody's talked about Thailand, and everybody's pointed out about the 30-year work between 1970 and 2000 that went on in order to build primary healthcare systems in that country. You might be surprised to know, we talk about healthcare expenditures being perennially low in India, but you might be surprised to know that India spends around 3.94% of its GDP, although it's only around 1% of the GDP that the government spends. 4% of GDP is spent in healthcare in India. Thailand does the same thing. They spend 4% of their GDP. When they started out with UHC back in 2001, they only had $1,900 per capita per person. But today they spend around $600 per capita on a purchasing power parity basis. Their actual spend is around $370, $400. And they have health outcomes as good as anybody else in the middle income world. So what did they do right? They did a few things right. I mean, as we pointed out, they built primary healthcare systems. Second, when they started out with UHC, they shunted off money from their central hospitals into these primary care systems. Nobody talks about that because it's not pro-market probably. It does not expand on business, but that's what they did. They also limited all their health expenditures to government expenditures. So 86% of health expenditure in Thailand happens within the government system. Only 14%, that's a lot of medical tourism that happens in the private sector. So these are the kind of innovations that you have to engage in. But a very interesting example, what I would consider the stellar example of reformatting your healthcare system in order to deliver the goods for people is from Costa Rica. I mean, and that was not easy work. That took 50 years of work. It started in 1961, even before UHC became fashionable in 2005, even before Health for All became fashionable in 1978. Costa Rica started out in universal health coverage for everybody back in 1971, with an aim to providing healthcare for everybody in 1961, with an aim to providing healthcare, primary healthcare for everybody in 1971. They did well for 10 years. It didn't go as well as they thought, but they did focus a lot on building those, the difficult part of building community-centered healthcare systems. So they built the system called Rural Health Program, where around a population of around 5,000 people would be in charge of a doctor, a nurse, a pharmacist, a medical clerk, and an information person, and they would not only provide a comprehensive set of healthcare interventions, but they also would go out and reach to the community with a community health worker and provide all the things that they needed to do in order to link up people and their livelihoods with the healthcare system. So that has paid rich dividends over, the 50 years. The other policy innovation that they did was they actually decoupled their primary healthcare system from the Ministry of Health. And they put it into their Social Security scheme. What that ended up doing was the funding cycle was predictable. The money that came in from the Social Security scheme was always there, even in the low days, in the dark days of 1980s when neoliberalism and contraction of the state was expanding all across Latin America. That did not really affect health systems in Costa Rica as much as they did in, say, for example, Mexico or some other countries. So that has resulted in a situation where, although Costa Rica spends around 10 to 12% of what per capita health expenditures are in the United States, their infant mortality rate is comparable. Their life expectancy is, in fact, slightly higher than the United States. Sad as it is. So focus just on primary healthcare system. That's the kind of achievement that you can have if you focus on providing the right kind of care. But that's a very difficult conversation to have, and that's an even difficult thing to do. So we don't talk about that enough, and I think we need to talk about that more if we are going to have even a passing shot at improving health outcomes, at improving healthcare delivery systems in Bihar by means of Ayushman Bharat. If we don't do that, we've had 15 years of state-level health, insurance experience in India, and none of that has really delivered the goods except in some exceptional situations. And I think that's all that's going to happen. At best, what we're going to see is an expansion of the private healthcare delivery systems without a commensurate increase in delivering the healthcare goods for people.
Thank you so much, Dr. Pandey, for the insights. And just to summarize, what he means is probably, if I have the liberty, that health and healthcare are not the two same things. Healthcare just is an input into the production that goes to create health. There are many other inputs as well, which include sanitations, which include not only tertiary healthcare coverage, which Ayushman Bharat, as we know, provides, but other forms of inputs such as wellness and fitness and so on and so forth. It has to be a holistic approach. So it was a very nice discussion, people coming from different backgrounds, giving their opinion about it. We are running out of time, but I do not want to leave the opportunity for the audience to ask a few questions.
From ICT International. I'm trying to contextualize my question, in relevance to the theme of the panel, Ayushman Bharat, and also coming from the climate change lens. Given that, climate change will exacerbate, the risks which are, primarily in the domain of primary and secondary health care. I wanted to, pose a question to, the entire panel. My concern is to strengthen healthcare, primary healthcare. So, how would you respond if I asked, how can you strengthen primary healthcare delivery services, quality services? Can you strengthen primary healthcare quality services through including primary healthcare in Ayushman Bharat by linking, the doctors in the rural areas to payment, performance-based, incentive-based payments?
This is to Professor Malani. There's something about market equilibrium here I'm missing. That is, if people could have gone to the public hospitals in the first place, which was one of the reasons why utilization increase wasn't so high, why didn't they also think of that as financial protection? That is, what credibility did the program give them that the existence of the public alternative didn't give them, since it affects the quantity but not the financial attitude? The second, related to that is there any information on what this might have done to prices in private facilities?
Question is to Anup. Anup, did you at all look at what the impact was of the insurance program of people who were not covered? Because the fear is that with Ayushman Bharat, some people will come under coverage and people who were utilizing those facilities earlier may get pushed out. So you may have adverse health consequences for a certain group of people.
And my question is for Tarun. Tarun, that was a wonderful presentation. The question I have is those 3.3 million hospitalization or procedures that you cite. 3.3 million divided by 8 is 400,000 per year. If you assume very generously, given Andhra Pradesh's population of 80 million, the 60 million were covered by Arogyasri, that would mean a 0.75% hospital use. But we know that the hospital use rates among richer groups are much higher. So do you really believe that if you had a very generous scheme, it would remain at 0.75, and therefore would like to rechange your assessment of rupees 200 per person as being an appropriate cost?
My question is to the entire panel when we talk about Ayushman Bharat in total, and then we highlight about the numbers that this much patients are availing treatment at private hospitals, and there is an uproar about this thing. But we never boost about the augmented facilities and services and people availing them at public health facilities. So is it killing public health system slowly?
Healthcare. So there is a variety of experience in this area, including government of India itself attempting to pay for performance in primary healthcare. But what is the global evidence and what is being talked about that individual-based incentive rarely function or rarely deliver outcome. So the only option left is a team-based incentive that have shown some impact. But the challenge in setting like India is that we work in a setup or system where there is a limited data available on which you can pay for their performance. So it will be very challenging, but it's something worth exploring, mainly team-based incentive. But it's really required some capacity building, some data strengthening before you can arrive at what formula in a setup where health worker keep complaining they are already underpaid. So what proportion should be their fixed salary and what proportion should be their incentive-based salary? So those are the challenges. So that's a separate debate. Summarize, yeah, it is possible, but with its own challenges. I quickly want to reflect upon, since you raised the issue of climate change and how health system can be prepared. I think the new discourse, and which is again academic, but academic discourse reaches a point where they become operational also. That till now the program were in India or many countries were focusing upon vertical oriented or disease focus, that okay, this program will deliver this thing. And if we talk in terms of climate change, that will not be the appropriate approach. Rather, the new approach which is being discussed is that what services are needed at that level, be it primary, secondary, or tertiary, and who can deliver those. So that's another important discussion which should happen separately. Thank you.
Professor Malani, would you like to answer the other questions?
Sure. So thank you very much for those two questions. Let me address the first question, which is, or I don't know what the order is, but let me address the question about the impact on public facilities versus private facilities. So I think public facilities are already an existing safety net. RSBY in some sense just expanded the safety net to allow you to go to private facilities. If public was an adequate safety net, then you're not going to see, that may explain exactly why there was an increase in utilization, so you're correct there. Now in theory it's possible that what happened is RSBY provided demand side incentive that would increase increase the amount of private facilities there are. I think there's value to increasing private facilities. In theory, it's possible. However, we don't have great evidence on that actually occurring, and the reason is we don't have a great census of beds or hospitals, and I think that's something that we ought to do, and if we're going to do something like Ayushman Bharat and properly funded, then it's going to be the case that you could have a big impact on the private sector in terms of private facilities, but we need to measure that, and we don't have the data to do that. One limitation I think that's important is that prices are low for Ayushman Bharat now, and nor do they reflect differences in the cost of production in rural areas versus urban areas. Unless you do that, what you'll see is mainly effect on private facilities in rural areas, but not in urban areas. The second question is about whether or not there's spillovers. We think that when we started the study, we thought that was a real big concern, that if you provided formal insurance for some people, you could crowd out informal insurance for uninsured people or affect the credit markets for them. And we actually designed our study to address that very question. So we varied the fraction of people that got insurance across different villages, and we randomized in order to get the impacts, those spillover estimates. However, we found that there were no spillovers that we could find from the people that were insured to the people that were uninsured. To some extent, that's quite reassuring in the sense that there could have been negative spillovers, and we don't observe that. Let me stop there so other people can comment.
So to come back to the last question, which I found really interesting, and this is interesting especially after the slide that was put forward by Dr. Narayana, which showed that there are very few private hospitals which has actually got themselves impaneled in Bihar. So as a result, what might happen that all these patients will be pushed towards the public health facilities, and we all know there are multiple evidences that they are already overburdened. So they will be handling huge number of patients, and that might even further deteriorate the quality of the tertiary care that they are providing. So I would like the Principal Secretary to try to attempt to answer that question, and also to summarize the entire discourse on the new health program, the Arogyasri program. Over to you.
There is an issue as to what Ayushman Bharat's impact is going to be on the public health facilities. In fact, when we first saw the program, and when we saw that secondary care also may be given in private healthcare centers, we were a bit dismayed. Because in a state like Bihar, I guess we are still in the process of strengthening primary and secondary health care. When we started, whenever a program is started, you're always in a hurry. And there is instant results to be shown. And you are being asked to do that. So the easiest was to also impanel the government hospitals, which were already there. So in fact, if you look at Bihar, we have just about a little less than 600 hospitals which are impaneled in this particular program. And out of that, about 540 of them are public health facilities. But there's also, the caveat is that we also think that this is also an opportunity to improve the public health facilities, leveraging on Ayushman Bharat. If Ayushman Bharat, anyway, the treatment in the public health facilities is free. So if you provide absolutely free services and you get that much amount of money transferred by the state health agency to your hospital, you can utilize that money for giving incentives to your employees there and also for strengthening the infrastructure. So the government of Bihar has taken a decision that whatever money goes to a public health facility, they can use 70% of the money for strengthening the infrastructural facilities of the hospital and 30% for distribution amongst their employees as incentives. I have a few random points which I would just want to mention it for you. Most of the private hospitals well-known hospitals have not impaneled under Ayushman Bharat. Even in Patna, I think Paras and other big hospitals have not come. But if you look at Paras Hospital, there some of the better doctors there in Paras don't operate at CGHS also, because they want more than that. And the package rates are low. So what is the sign is that low level of hospitals will come. We are a little mindful of that because we don't want fly-by-night operators, and I can tell you that the kind of information asymmetry which you have in healthcare services, you don't see in any sector. You go to a doctor and he tells you that you take this antibiotic or you need to undergo this particular surgery, you have no information to counter it, other than to say, yes, sir, let me see where I can get the money. How do you decrease health asymmetry, health information asymmetry? I think that to a very large extent, it is going to make the system transparent in the long run. We need to work on that. Government of Bihar allows private practice. It has, so many of our doctors who are working in the public health facilities are also doing private practice. It has created a very strong conflict of interest. And we are worried about that. But with this kind of a conflict of interest, can I really strengthen my public health facilities? I would want to pose a question to people who are here. Can you sit with us and help us design an incentive system for people who are part of the public health system in the state? I'll be very happy to sit with you all and work out an incentive system, because as of now, I get a feeling that if you are part of the public health system in Bihar, I'm not talking of elsewhere, your incentive is in collapsing the system. You make more money by collapsing the system than rather strengthening the system. So actually, if you are a part of it, there is no sense of ownership that this institution I work. There may be a lot of difficulties. We are overworked, there are less, you don't have equipments and other things, but your basic incentive is that the more the system doesn't work, you look outside and you make money. I would actually be very happy if any of you would be interested in sitting with us to design a kind of an incentive policy for people who are part of the system. There was an issue for universal health coverage. I think we can have a long debate. Second point I want to tell you is that we've been running government programs for a very long time. What is the continuity of programs? Because that ultimately is going to impact. We started RSBY, how long did we do it? Then we moved on to a new scheme. I remember when I joined the service, on 2nd October 1989, Jawahar Rozgar Yojana was started for rural development. Every year we made changes in it. So much so that after a few years, the program didn't look like what it was started with. I'm just saying is that there should be continuity in running a program. China has taken more than 15 years of time to put in an insurance-based policy there. And the system is still not perfect as the data was being shown. And we do things, it's a closed room, so I can say, what happens to Ayushman Bharat after June 2019? Can anyone say it with certainty the program will continue or the program will undergo a metamorphosis? Second point I want to say is that who are the people who are running it? When you sign an MOU with Government of India under National Health Mission, one of the points is that whoever you appoint as the Managing Director of NHM, Mission Director of NHM, he shall have a 3-year term, right? When I joined NHM in 2010, the predecessors before me, the average tenure of a mission director in NHM was 6 months. I stayed there for 4 years. When I left, I think the average has come down again to about 8 or 9 months. Now, Manoj is here. Manoj is the CEO of Bihar Swasthya Suraksha Samiti. He's going to run the program. I really don't know how long Manoj is going to stay in that program. You need to have continuity in program and in leadership. Someone mentioned about Muskan Abhiyan, that in 2004, our routine immunization figures were terrible. But we have done a good job, and we take pride in the fact. But why has it happened? Because the Chief Minister personally took interest in it. Every time I'll meet the Chief Minister, he'll ask me, how is the routine immunization going on? So, there is a leadership initiative. If the leadership initiative is there in any program, the program picks up. And if it is monitored on a regular basis, then it does even better. One more point I would want to say, because I got a chance and you are listening to me. Our health system is a little too doctor-centric. We need to move away from it. I mean, at least in Bihar, we have just not empowered the paramedics. There is a whole ecosystem in health system which is led by the doctor, but it has become too doctor-centric. We need to focus our attention on the fact that how do I make the system a little more representative. Doctors, of course, would be there. They will be doing all kinds of things, but things can also happen. Can we bring in a public health management cadre, empower it, and ensure that the doctors only do operations? If the Prime Minister is traveling abroad, he doesn't have to care that who's going to book the Air India plane and who's going to do this. He just walks in and sits in the plane. There is a whole system, there's a whole ecosystem which is managing all these affairs. But what are we doing? We have not put burden on all kinds of people, and unfortunately what happens is the guy who works, he gets overburdened. So the incentive is not to work. N. Vittal used to be the Chief Vigilance Commissioner once upon a time, so once he wrote I read an article by him that in India, if you work very hard, I think the only reward you get is more work. And if you don't work, then you get the 3 Ps, pay, perks, and promotion. So this is the incentive system which needs to be looked into. And I think I'll just respond to D. Narayana Sahab because he was mentioning a few things about our IMR, and my infant mortality rate is going down. It is down to 38. By my neonatal mortality rate is not going down. So that means out of every 38 children who are dying in 1 year, 25 of them are dying in the first month. So I need to have systems by which I look at the first 1 month, and that means I will need to look at facility-based systems by which I can save these children. Unfortunately, it requires expertise, it requires attention to detail, and that we are trying to work as of now. Someone also mentioned, one of the panelists, about the rare experiment being done in Maharashtra. I guess you were referring to Gadchiroli. Yeah? Many of these initiatives are actually driven by visionary people. And unfortunately, its scalability and replicability becomes a suspect. So when you're very good and you run something extremely well, it is running because of you, not because of the system. So when you actually import the system and put it in your place, it doesn't work that well. We have started Ayushman Bharat. I'm pretty hopeful that if we work and if we create, Stuti was mentioning, ultimately it boils down to the fact that what kind of a capacity we have to run these programs. Often we do things on an ad hoc basis, and it doesn't pay, and then what happens is the sustainability of the program itself becomes questionable at times. So we have started a program. I sincerely wish that we sustain it for the next 10 years, 15 years of time. Then probably I think what Ajay ji was mentioning, that we will not have 0.75, you might have a larger number. But then let me tell you that when RSBY was running, I think even the heydays, less than 2% of people were actually mentioning it. The last point with which I would want to sum up is that there's too much rent seeking in the system of health. When we were running RSBY, we had a so-called uterus scam. I mean, imagine, you can have all kinds of scam, but we had a uterus scam. What happened? All these young girls who were going to these private hospitals, 19-year-old, 20-year-old, 21-year-old, they underwent a hysterectomy. Their uterus was removed. It was a big scandal. It completely marred and impacted the program. Everyone started looking at it with great suspicion and suspect. But actually no one went into the reason for it, as to why are women undergoing hysterectomy? In a country where menstrual hygiene is so poor, you get urinary tract infection, you get intrauterine infection. It hurts. You go to a hospital, they tell you 2 options. Go through a conventional treatment, maybe it will take you a year or 2 or something, but you will be rid of the pain. But the simplest solution is you undergo a hysterectomy. Let me take out the uterus, you will be saved of the pain. Now you as a person, you have to make a choice. There is no one to counsel you. There is so much asymmetry in the information, and of course, rent seeking is genetically implanted in many of us. creates all kinds of difficulties. Ethics will have to be brought in. I often hear, and I tell my doctors that, they come and tell me that, look, we are being beaten up. I always say that, have you seen the movie Spider-Man? In Spider-Man, the uncle tells that with great power comes great responsibility. If you want to enjoy the power, learn to be responsible. And if you're not responsible, power will not going to come back to you. Thank you.